Hi everyone. In this video we're going to be taking a detailed look at localized renal cell carcinoma, and this video has been made specially for those people who have the illness themselves or have a loved one who has been diagnosed with RCC and wish to learn a little bit more about it. So in the video we're going to be covering 4 major topics. We'll be beginning with epidemiology, followed by a focus on localized renal cell carcinoma, and then staging and grading, and then finally ending off with a look at surgical management of RCC. Now you have the option of watching the video in sequential order, or if you're interested in learning about only 1 or 2 of these sections, you may go ahead and click on the section that you wish to see now. So in terms of epidemiology of the disease, the highest incidence rates are seen in the Czech Republic and countries of North America. And within these regions, individuals with North European ancestry that can be traced back to Scandinavian countries in particular present with an incidence rate that is higher than that of the rest of the population. And in particular, it's higher than the incidence rates that we see in individuals with African or Asian ancestry. And statistically speaking, in the United States, we see about 65,000 new cases appear each year of RCC, and in the recent past, this incidence has been increasing at a rate of about 2.6% per year. Now, this increase in incidence does not necessarily mean that more people are getting renal cell carcinoma as compared to the past. In fact, it's largely due to the fact that there is widespread use of non-invasive abdominal imaging modalities these days, and which allow us to detect asymptomatic tumors. And as you can imagine, because we're able to detect asymptomatic tumors through incidental findings, the size of tumors at presentation is decreasing, with more and more patients presenting with stage 1 disease. Now, in terms of localized versus non-localized disease, about 60% of patients present with localized disease at the time of diagnosis, 19% with regional disease, meaning that there is involvement of the regional lymph nodes, and about 21% of patients present with metastatic disease, in which the cancer is no longer confined to the kidney and it has spread to distant organs within the body. Also, looking at the gender and age differences that we see in patients with RCC, RCC is 50% more common in men than it is in women, and it typically shows up in about the 6th to 8th decade of life, and it's thought to be uncommon in individuals under age 40 and very rare in children. So importantly, when RCC appears at an early age and the kidney tumors are multifocal and bilateral, meaning that they're present in both kidneys, we can suspect a strong genetic predisposition towards the development of the disease. So now looking at mortality rates that are associated with RCC, the 5-year survival rate has more than doubled in the past 50 years, and it has gone from 34% in 1954 to about 69% in 2002. And this improved case fatality rate makes sense given our previous discussion, because incidental findings allow for earlier diagnosis and earlier potential surgical intervention as well. So apart from this, there's many risk factors that predispose people to the development of RCC. And we're going to talk about some of these factors that are listed below in a little bit of detail. And beginning with smoking. Smoking is one of the most significant risk factors for the development of RCC. It more than doubles the risk of developing this disease. Also, the risk of developing RCC increases with increased use of cigarettes. And additionally, the increased use of cigarettes is also associated with more advanced disease. Next is hypertension. And hypertension is thought to increase the risk of developing RCC independently of antihypertensive medication and obesity. Following that, we have diabetes mellitus. And diabetes mellitus is associated with a moderately increased risk of developing RCC that is considered to be mediated through an increase in the incidence of hypertension itself. Then we have occupational exposure, and this is talking about occupational exposure to toxic compounds such as cadmium, asbestos, and petroleum byproducts, which also increase the risk of developing RCC. And these compounds may be associated with mutations to genes that are implicated in the pathogenesis of RCC, such as the VHL tumor suppressor gene. Following that, we have obesity, and it's considered also to be a major risk factor for the development of RCC. And it is thought that the global rise in obesity rates may in part be contributing to the increased incidence of RCC. Next, we have acquired cystic disease of the kidney, and this disease occurs in about 50% of people who are chronically dependent on dialysis machines. And once an individual has this disease, acquired cystic disease of the kidney, the risk of developing RCC is about 30 times greater in these patients than it is compared to the general population. And if it is going to develop, it develops usually after about 8 to 10 years of using dialysis. Following that, we have abuse of pain medication, which also predisposes one to the development of RCC. Now, VHL disease and tuberous sclerosis are inherited diseases, which also increase the risk of RCC. And we're going to be talking about the VHL gene and the disease in a little bit more detail later on. Next, we have family history of kidney cancer, which is also a significant risk factor for RCC, because sometimes we see this cancer appear in clusters within families. And then lastly, we have age and gender, which are also risk factors for RCC, as we discussed before. So prognostic factors, which determine in part how a person will do after they have developed RCC, include the pathologic stage of the primary tumor, which we're going to be talking about in some detail later on as well. Whether or not there is regional lymph node involvement also partially determines how someone's going to do given this disease, and then followed by the nuclear grade and the histologic subtype of the tumor. In this section, we're going to take a detailed look at localized RCC. So just beginning by putting things into context, RCC refers to neoplasms that arise from the renal cortex and accounts for about 3% of all adult malignancies and about 90 to 95% of all renal neoplasms. Clinically, a classic triad that comprises of flank pain, palpable mass, and hematuria is considered to be characteristic of RCC, but it is only present in about 10% of all cases. And when it is present, this classic triad indicates advanced disease. And other symptoms that we see arising due to this disease are weight loss to a great extent, fever, hypertension, and to a lesser extent we see night sweats and malaise. Next, we're going to talk about paraneoplastic syndromes that are associated with RCC. And paraneoplastic syndromes are basically non-metastatic systemic effects of the tumors that are caused by substances that are released by the tumors themselves. Now, RCC tumors release cytokines in the form of erythropoietin, interleukin-6, and nitric oxide, which go on to cause a variety of these syndromes that are listed here. And these include erythrocytosis, non-metastatic hepatic dysfunction such as Stauffer syndrome, amyloidosis, anemia, and to a greater extent, fever. Now, it's important to note that RCC is not just one large entity. There are subtypes that exist that are important to distinguish from one another because there are important differences in biologic behavior and prognosis amongst these different types of tumors. Typically, we see the clear cell variant in about 75 to 85% of RCC cases. The papillary type we see in 10 to 15% of cases, chromophobic subtype 5 to 10% of the time, and other variants such as collecting duct are very rare. So what we're going to do now is we're going to take a closer look at all of these variants to be able to learn a little bit more about each one of them. So beginning with the clear cell variant, it is the most common adult renal malignancy, and this tumor arises from the epithelial cells of the proximal convoluted tubule of the nephron. And about 40% of individuals who have VHL disease, which we discussed earlier on to be a significant risk factor for the development of RCC, develop RCC, and most commonly they develop the clear cell variant. Genetically, the chromosomal abnormality that is most closely associated with clear cell carcinoma is the deletion of chromosome 3p. Also, histologically, tumor cells are arranged in nests amidst an extensive network of vascular channels, as is seen in the image above. And in the lower image, you can see that the cells have a clear cytoplasm, which is due to the abundance of glycogen and neutral lipids in the tumor cells. So, along with heavy vascularization, this clear cytoplasm in tumor cells is considered to be characteristic of the clear cell variant, hence the name. And overall, the prognosis of this RCC variant is worse than that of type 1 papillary RCC, as well as chromophobe RCC. So next we have papillary carcinomas, and as mentioned before, these account for about 10 to 15% of all renal carcinomas. And like the clear cell variant, papillary RCCs too arise from the proximal convoluted tubule of the nephron. And frequently these tumors tend to be multifocal and bilateral, meaning that they appear in both kidneys, and they are also usually small and early stage. Now, the genetic abnormalities that are associated with papillary RCC are quite numerous, and they include trisomy 7, 12, 16, 17, and 20. And in terms of histopathology, the tumor is composed of papillary projections that are lined by a layer of tumor cells. And within these papillary projections, we can find a fibrovascular core that also contains foamy histiocytes, which are characteristic of papillary RCCs. In addition, neutrophil infiltration into these fibrovascular cores is also a characteristic that helps us distinguish this variant from other closely related RCC variants. Now, additionally, papillary RCC can be further classified as type 1 or type 2, with type 1 being low grade and carrying a better prognosis than type 2 tumors, which are of a higher grade and obviously have a worse prognosis. So next we have chromophobic carcinomas, and these account for about 5% of all renal neoplasms in adults. And unlike the previous two variants, these tumors arise from the intercalated cells of the collecting system. And the genetic abnormalities that are associated with this variant are a hypodiploid number of chromosomes, and these affect chromosome 1, 2, 6, 10, 13, 17, or 21, which are listed on the slide. And in terms of histopathology, the cells appear in solid sheets that are darker than clear cell RCC. Also, as you can see in the image below, the cell membranes are quite distinct, and there is perinuclear clearing due to retraction of the cytoplasm around the periphery. And prognostically, the 5-year survival for this variant is better than that of clear cell carcinoma. So lastly, we have collecting duct carcinoma, which is also known as Bellini's duct. And this variant is a rare form of RCC which occurs in younger patients typically and is frequently very aggressive. And characteristically, the cancer cells form irregular tubes and occur in a tubulo-papillary architecture, which helps us distinguish this variant from other RCC variants. Also, the smaller tumors of this type are usually confined to the medulla, whereas as they grow larger, they are able to invade into the cortex as well. So now we're going to talk a little bit about the oncocytomas as well. Although it is important to point out that they're technically not a type of RCC, because these tumors are invariably benign, and this means that they are well encapsulated and are rarely invasive or metastatic. Now, they're similar to RCC tumors because, like some variants, they too arise from the intercalated cells of the collecting duct. And although themselves are not a type of RCC, there is a coexisting RCC in about 10 to 32% of cases. So it's very important for doctors to be wary of this fact and to make sure that individuals with oncocytomas are being followed up to see if they have any of these complications. So even though these tumors are considered to be benign, they may damage adjacent renal parenchyma as they grow in size, and they can grow to be quite large in size. And histologically, the oncocytes that comprise this tumor have a granular cytoplasm, and this is because of the abundance of mitochondria. And in addition, these oncocytes are arranged in nests that are separated by a loose fibrostroma, as is seen in the image over here. In this section, we're going to be discussing the staging and grading methods that are most frequently used for renal cell carcinomas. So, beginning with the TNM staging system, TNM stands for tumor node metastases, and it is used to stage all variants of RCC. And the system was recently revised in 2010 and is supported by both the American Joint Committee on Cancer as well as the International Union for Cancer Control. So essentially, the TNM criteria that is considered for the staging system is used to define the anatomic extent of the disease, and it's relatively straightforward and easy to understand. So beginning with the T category then, the T category is used to indicate the extent of the primary tumor, which is of course located in the kidney. TX means that the tumor cannot be assessed for any reason. TO means that there is no evidence of the primary tumor, and this is obviously what we would expect to see in a healthy individual. T1 means that the tumor is 7 centimeters or less in its greatest dimension and is limited to the kidney. And importantly, T1 can be further broken down into T1A and T1B, which have been included on the slide for your information. T2 indicates that the tumor is more than 7 centimeters in its greatest dimension, but is still limited to the kidney. And like the one before it, this category can also be broken down into T2A and T2B, which have also been included on this slide. Now, stage of T3 indicates that the tumor extends into the major veins or perinephric tissues, but has not infiltrated into the ipsilateral adrenal gland and not beyond Gerota's fascia. And T3 can also be broken down into 3 subdivisions, including T3A, B, and C, which have not been included on this slide for the purposes of conserving space. And lastly, we have T4, which means that the tumor has invaded beyond Gerota's fascia and has extended into the ipsilateral adrenal gland. Now, the other 2 parts of the staging system are simpler. So for regional lymph nodes, NX means that the regional lymph nodes cannot be assessed for whatever reason. NO means that there is no regional metastases, and N1 means that there is metastases in the regional lymph nodes. And lastly, in terms of distant metastases, MO means that there is no distant metastases, and M1 indicates that there is distant metastases. So once we've established T, N, and M stages individually, we can combine them to assign patients into prognostic groups. And as we mentioned before, the staging of the tumor, of the primary tumor especially, is an important prognostic factor in RCC. So, for example, as seen here, patients in whom the tumor is less than 7 centimeters in greatest dimension and who have no regional lymph node involvement or distant metastases have stage 1 disease. But on the other hand, in individuals whose tumor has invaded beyond the Broca's fascia and into the ipsilateral adrenal gland with any N and no metastases are considered to have stage 4 disease, as well as those patients who have any T, any N, but have distant metastases. And you can see these demonstrated to some extent in this image on the right here as well. So now we're going to look at the Furman grading system, which categorizes all variants of RCC based on their nuclear characteristics, essentially by assigning them a grade from 1 through 4. So what it's really doing is that it's giving us an indication as to how closely the tumor cells are related to normal kidney cells. And obviously for grade 1 tumors, the tumor cells are more closely related to kidney cells than are those for grade 4 tumors. And also grade 1 tumors are slow growing and are associated with a better prognosis than grade 4 tumors, which carry a worse prognosis. Now it should be clear that the nuclear grade is independent of the tumor type, meaning that we can assign a nuclear grade to all variants of RCC. And having said that though, even though we do use the Furman grading system for all RCC variants, studies have shown that it has limited prognostic value in papillary RCC. So in this top image over here, you can see an example of grade 1 clear cell RCC. And characteristic of grade 1 tumors, the nuclei here are small and the nucleoli are not visible. Additionally, there is little detail in the chromatin. And in contrast, in this lower picture over here, which depicts grade 4 clear cell RCC, the nucleoli are pleomorphic with open chromatin or hyperchromatic and have single or multiple macronucleoli. In this section, we're going to be discussing the surgical management techniques that are in place for the treatment of localized renal cell carcinoma. And specifically, we're going to look into radical and partial nephrectomies, followed by some of the newer ablative techniques that are also available today. So beginning with an overview, surgery is considered to be curative in patients without metastases and is therefore the preferred treatment for patients who have stage 1, 2, or 3 disease. And as it stands now, it is the only curative treatment that is out there for localized disease. It also plays a role in metastatic disease, and that is a role of primarily palliation. Now, the two major goals of surgery are to completely remove or destroy the tumor while preserving as much kidney function as possible. In terms of the mortality rates and the risks associated with nephrectomies, it's important to note that nephrectomies are a common surgery and thousands of nephrectomies are carried out each year for the removal of renal masses as well as other diseases. So the surgeries are generally regarded as being low risk, and in patients with no metastases, the risk of mortality due to the surgery is less than 1%, and the risk of mortality in patients who have metastases is very similar, and that is around 1%. Now, complications due to the surgery are uncommon unless there is extension of the tumor into the renal vein, the IVC, or beyond the kidney. And in terms of post-surgical recurrence rates, about 20 to 30% of patients still develop metastases even after they've had a nephrectomy. And the predictors of relapse include symptomatic disease, high Furman grade of the tumor, a high pathological stage of the tumor, microvascular invasion, as well as necrosis. Now we're going to be looking into radical nephrectomies and nephron-sparing approaches in more detail. So beginning with radical nephrectomies then, this procedure involves complete removal of the Gerota's fascia and its contents. And this includes the kidney, the perirenal fat, which is the fat that surrounds the kidney, and depending from case to case, also the ipsilateral adrenal gland as well as the ipsilateral lymph nodes. Importantly, removing the kidney as well as the surrounding fat is important because it provides a better surgical margin than removal of the kidney on its own. And this is because of the possibility of perirenal fat involvement. Now, according to the 2011 National Comprehensive Cancer Network Guideline, removal of the ipsilateral adrenal gland is recommended if it appears to be abnormal on a CT and when removing the large upper pole tumors. And otherwise, adrenalectomies are not indicated. And as far as lymph node dissection goes, the value of doing this is more prognostic than it is therapeutic, and studies have shown that it does not lead to any significant difference in time to progression, progression-free survival, or overall survival for patients. Also, radical nephrectomies are necessitated in the case of IVC involvement, since this condition precludes a partial nephrectomy. And it is also the standard of care for stage 2 and stage 3 tumors. And lastly, radical nephrectomies can be done through both an open or a laparoscopic procedure, and we're going to be looking at a comparison between these two types of procedure later on in the video. Now we're going to briefly talk about the surgical procedure when there is IVC involvement. And we see IVC involvement happen in about 5 to 10% of cases. And when it does happen, it's more common on the right side than it is on the left. And in terms of how patients with IVC involvement do, there's about 55 to 68% 5-year survival rate for patients with IVC involvement if there is no nodal or distant metastases. So generally, they're able to do quite well if the tumor has not spread. Now, in terms of the procedure, the surgeon has to essentially gain control of the inferior vena cava both above and below the tumor thrombus. And that's a part of the tumor that is extending into the IVC. Now, in order to do this above the thrombus, the liver is reflected medially, and you can see that in the image below on the left. And also, you want to gain control of the contralateral renal vein. So you can see that in this image, it's the left renal vein that has been clamped because the tumor is coming in from the right. Now, after that is done, the tumor thrombus and the entire kidney are removed as a whole. And you can see this on the image on the right. Now, this procedure becomes more complicated if the tumor thrombus has extended above the diaphragm, and in this case, the patient is put on a bypass for the duration of the surgery. So now we're going to look into partial nephrectomies, which are also called nephron-sparing surgery. Now, in accordance with the 2011 National Comprehensive Cancer Network Guideline, partial nephrectomies are indicated for masses that are less than 4 centimeters in greatest dimension or are between 4 to 7 centimeters in greatest dimension. Basically, what this procedure is doing is that it is removing the part of the kidney with the tumor as well as some normal renal parenchyma, and that's done just to ensure that all the cancer cells have been removed. And you can see that in the image on the right here, which depicts a laparoscopic partial nephrectomy. And partial nephrectomies are ideal when compared to radical nephrectomies for certain types of individuals. And these include people with a single kidney, people who are experiencing poor kidney function, or have a genetic disease or bilateral kidney tumors. However, it is not possible in people who have IVC or renal vein involvement, as we have discussed before. Now, like radical nephrectomies, partial nephrectomies can be done through both an open or laparoscopic procedure, although laparoscopic partial nephrectomies require a great deal of technical expertise, and only a handful of surgeons are available to do this at this time. On this slide, we're going to now look at a comparison between open and laparoscopic procedures. So it's important to note that both procedures are similar in their complication rates and have shown to be equally effective for tumors that are confined to the kidney. So now, beginning with a description of the procedure, this generally involves one large incision made in the patient's side, abdomen, or lower back, and here we're talking about the open procedure. Now, in contrast, laparoscopic procedures are minimally invasive, and they're performed using a laparoscope after making several small incisions in the abdominal cavity. And usually we're looking at about 3 smaller incisions and 1 larger incision through which the actual mass is removed. Next, the open procedures are suitable for large and more advanced tumors, whereas laparoscopic procedures are used for smaller, localized renal tumors or tumors that have not yet spread beyond the kidney. Now, in terms of advantages and disadvantages, the laparoscopic approach has many advantages over the open approach, and some of these have been listed here, and they include less morbidity, less scarring, so it's obviously cosmetically superior, shorter recovery time, and subsequently a shorter hospital stay, as well as reduced need for pain medication following surgery. Now, there's also a few disadvantages of the laparoscopic approach, and one of the major concerns in a laparoscopic nephrectomy is technical difficulties in being able to define the surgical margins. Also, as mentioned before, laparoscopic procedures, and especially partial nephrectomies, require a great deal of technical expertise that may not be readily available. So patients interested in these procedures might have to look into traveling to the nearest center to get these procedures done. Now, this slide illustrates a laparoscopic radical nephrectomy, and you can see in the first image the primary port through which the laparoscope is inserted. The laparoscope is basically a thin tube that has an eyepiece at one end and a light and magnifying lens at the other end, and this allows the surgeon to see what he's doing once the instruments are all inside the patient's body. And the surgeon's hands go on the secondary ports that are also shown on this image here. And at the end of the procedure, the kidney is removed in an impermeable sac, which can be seen on the right. And because the sac is impermeable, things like spillage of the tumor cells into the body are prevented. Now we're going to briefly look at cryoablation and radiofrequency ablation, which are promising techniques due to a newer technology, and they're being brought into practice more and more so. Now, these are CT or MRI or ultrasound guided procedures that are conducted after a needle biopsy has been done typically in order to obtain the diagnosis. And they can be done either laparoscopically or percutaneously, making them also minimally invasive procedures. Now, cryoablation involves essentially insertion of a probe into the tumor, and this probe is used to freeze the tumor in a double freeze-thaw cycle. And the temperature at the tip of the probe is very low, and it is around negative 140 degrees Celsius. And in cryoablation, the surgeon is able to visualize the ice ball that's formed around the tumor, which freezes the entire tumor and a little bit of the periphery. And this is done to make sure that all the cancer cells have been destroyed. Now, RFA does the same thing, except this time instead of using freezing techniques, it is using heat. But in this case, because there is no ice ball formed that can be visualized, making sure you have destroyed all of the tumor cells is a bit more difficult. Now, overall, These procedures are considered to be minimally invasive, like I mentioned before, and for that reason, they are used in patients who have significant comorbid conditions. And it's important to keep in mind that these techniques are newer, and although we lack long-term follow-up data at this point on patients who have had these procedures, the 3-year and 5-year survival data on patients looks very promising. And this concludes our discussion on localized renal cell carcinoma.